Hey guys, so today we'll be doing a respiratory assessment and speaking through the steps in which we as clinicians perform in order to come up with a diagnosis when attending cases that have come down as respiratory. So we need to keep in mind that a systematic approach when completing this assessment allows a complete overview of a patient's condition. By doing the systematic approach, it allows us to collect objective data, which then allows us to diagnose and establish a provisional diagnosis and treat and manage that accordingly. So initially, clinicians will start with a primary survey that contains 5 steps. So our first step will be danger. Initially, you will check for danger to yourself, your partner, the patient, and any bystanders that are present. Next step will be a response from said patient. You can break that down into 4 parts. So you have a patient that is alert, which is exactly how I'm presenting right now. I am alert, I am aware of my surroundings. The next step would be a patient who responds to voice. So if a patient appears to have their eyes closed and you introduce yourself with, "Hi, my name's Ashley, I'm from New South Wales Ambulance Service. Can you hear me?" and they open their eyes, then they're alert to your voice. Upon introducing yourself, if a patient isn't responsive spontaneously or alert to your voice, you will then use a painful stimuli. That can be done by a trap squeeze, or you can do a squeezing of the fingers with a pen as well. That will initially warrant a response. If a patient doesn't respond to you by a painful stimuli, then the patient is classed as being unconscious. We need to keep in mind, though, with respiratory compromise, if there's signs and symptoms that are detected immediately that are classed as life-threatening, such as an airway obstruction, increased respiratory rate, accessory muscle use, pallor, cyanosis, hypoxia, paradoxal chest wall movement, or loss of consciousness, it warrants immediate management and treatment. Don't disregard these. You need to treat and manage accordingly to the symptoms that you come across. So, recapping 5 conditions that are primarily flagged as contributing to respiratory disease, we have asthma, COPD, acute respiratory infections such as pneumonia, chest infections, tuberculosis, or lung cancer. Moving on, our current scenario that we have been given is we are responding to a 65-year-old male whose chief complaint is shortness of breath. Upon completing your primary survey, we'll then move into our secondary survey. The first thing that I generally will do on scene is I like to take a set of vital signs. So upon taking vital signs, which include your blood pressure, heart rate, temperature, oxygen saturations, and respiratory rate, we've found that the patient has a blood pressure of 145 on 85, an 80 for a pulse rate, 95% for SpO2, 37.8 for our temperature, but we have a respiratory rate of 28, which is tachypneic as classed by textbooks and clinical standards within the ambulance service. Upon the completion of me collecting vital signs, I then like to move on to something that I use quite often, and it's an acronym called SAMPLE. So SAMPLE stands for signs and symptoms. So we're going to look for signs and symptoms of respiratory distress. Upon completing that step, we then move to allergies. Ask the patient, are they allergic to anything? The next part in that is medications. Have a look at what a patient's on with their medications, as that then indicates to you pre-existing conditions and can give you some idea of what the patient's health condition is in general. Moving forward, we go to previous, which is when was the previous time that they visited the doctor? When was the last time that they have been assessed by their GP or received medications? The next part in sample will be L, so that's the last time they ate or drank anything. Moving forward, it will be E, which is events prior. So what were they doing prior to the shortness of breath occurring? Now, moving on from sample, we need to keep in mind if the patient does state that they do have pain, we need to then also assess and manage that as well. So with pain, we can use a acronym which is OPQRST. So that stands for onset. So what time did the pain commence? Provocation. So does the patient do anything that creates the pain to become worse or less? Quality, they need to describe that pain to you. So is it a crushing, a throbbing, a stabbing type sensation? You need to establish if it radiates anywhere. So does it go up and down an arm? Does it move? Does it stay in the same spot? The severity, generally you can use the scale of rating your pain from 1 to 10, 10 being the worst pain, like your legs being chopped off. And the patient could then give you a rating of the severity of it. The last part of that assessment stands for time. So has that pain changed over time? Has it increased? Has it decreased? Once you can establish that, you then can move on to a more thorough assessment. So that will be at this point in time, given that our patient is experiencing shortness of breath and hasn't disclosed that he has pain, we'll now move into the respiratory assessment. So the first part of our respiratory assessment is inspection. When completing this component, we're going to be looking for things on a patient or that a patient is doing. Agitation or anxiety is key indication of a potential underlying conditions such as anxiety, or are they agitated and anxious because they're hypoxic? A patient's speech. So are they speaking to you in sentences, words, or phrases? A patient's skin colour will indicate an individual's oxygen saturations and also let you know if they are cyanosed. This is a form of assessment which can be conducted the moment patient contact is made, as visualization is the main key of this. So with inspection, you'll also look for things like a tracheal tug, nasal flaring, pursed lip breathing, which will be like that. It'll be a patient trying to suck in a fair amount of air because they feel short of breath. Your tracheal positioning is also an indication of respiratory distress, and the rate, rhythm, and pattern of a person's breathing. With infants or pediatrics, we can also look at accessory muscle use or recession. And we must also keep in mind that the symmetry, I should say, chest wall movement as well needs to be looked at. Edema, clubbing of fingers, or peripheral cyanosis are also indicators of respiratory distress. A way in which you can check for peripheral cyanosis is a capillary refill. So you can squeeze on a patient's finger and release, and a patient's finger, if they aren't cyanosed, will go from white back to the normal pink colour under 3 seconds. If a patient's cap refill takes longer than 3 seconds, there are signs of cyanosis there. So after the completion of inspection, we'll then move to auscultation. So that's the act of listening with a stethoscope to detect normal breath sounds. And we'll do that in a systematic approach. So we'll demonstrate on Toad here. So first and foremost, we will listen just above the collarbones to the bottom of the when listening, we're going to go from the collarbones to the bottom of the rib cage. So we'll place the diaphragm of the stethoscope anteriorly at the 8 pieces, moving symmetrically across the chest, comparing each side. So what we'll do is you'll tell a patient to just breathe nice and normal for me. I'm just going to have a listen to your lung sounds, no talking. So we'll listen as the patient breathes in and out. We'll then move to the next side. Do the same. You will make your way down and compare the sounds. We'll then listen to the back as well. And that's going to give you an overview of a patient's lung sounds. So adventitious lung sounds are additional respiratory sounds, and these can be present with particular conditions. So adventitious lung sounds, squeak. So a squeak can indicate pulmonary fibrosis or pneumonia. Crackles can indicate to a severe pulmonary edema or chronic cardiac failure. Wheezes in a patient can indicate COPD or asthma. A stridor is an upper airway obstruction, or we may be able to detect a pleural rub. So the next part of our respiratory assessment will be percussion. So we will do percussion along the back with fingers between the ribs. So hyperresonance will indicate a pneumothorax, and dullness can indicate fluid in the spaces. So what you'll do is you'll move down a patient's back while listening for a dullness, and that's going to indicate to you, like I said, if there's hyperresonance or dullness. So the next part of our assessment for respiratory distress will be palpation. So by doing this, we're going to assess a person's chest wall movement, and we're going to also look for subcutaneous emphysema. Now with chest wall movement, we can do that from the back. So you will have your fingers around a person's rib cage, thumbs together, and you get them to take a nice even breath in. You'll feel your fingers move, and they should come back together. That will indicate that a person's chest wall expansion and movement is normal. If that isn't occurring, then there is a problem that you will need to treat and manage. Subcutaneous emphysema will feel like cellophane, and you can generally feel that under a person's skin.